Good evening, everyone, and welcome to this evening's webinar, which looks to be extremely exciting. We're going to let people sign on. We'll give them another minute or two, and then we'll get going. Well, let's go ahead and jump in. I want to welcome everybody to our 26th webinar. This is a series that we've been conducting since the start of the pandemic. And I know a lot of you have attended several of these before. And tonight we're really very fortunate to have a extremely knowledgeable, talented, experienced cardiac surgeon who is going to talk about the STS database, which he has been instrumental in starting since its inception. But before I get to that, I'd like to introduce, my name is Al Stammers, and I'd like to introduce my co-moderator today. This is Dr. Eric Tisdale. Dr. Tisdale is the senior data scientist at SpecialtyCare and is responsible for many of the analyses that have been done through the COVID pandemic and before, and has worked very closely with Dr. Jacobs on those studies. I'm sure Dr. Jacobs will talk about that in just a second. But before I introduce just a couple of background details, I think anybody who's participated in this in the past, if you would like to receive the American Board Category 1 CEU credits, 1.2 have been allocated for this evening's webinar. Please not only stay in for his 45 minutes, I'm sure we don't have to say that with tonight's topic, but then complete the post survey. I'm going to show you the survey in just a second. The certificate is emailed out, usually within a week's time. And if you don't receive it or you have any issues with that, at the very last slide is going to be my email. Just reach out to me and I'll make sure you do receive it. As with all of our presentations, they're posted on YouTube, again, within a week's time period. As I said, the survey is very, very brief, just a few questions. So please take the time to fill that out. As with all of our webinars, we do have a Q&A session, and these are usually very robust and we receive a lot of questions. We try to get through as many as possible. Eric and I will be fielding those, and if you see one that you feel should be elevated to a higher level, just hit the like button on the question or write your own, and we'll make sure that we get to that. So with that, I'd like to begin, and this introduction would be very difficult to do in the brief period of time that I have, and so it's truly remarkable to see what Dr. Jacobs has contributed to the field of cardiac surgery, specifically pediatrics, but also adult cardiac surgery during his career. Dr. Jacobs received both his undergraduate and medical degree from the University of Miami, and then went on to do his congenital fellowship at Great Ormond Street in London. But right now, Dr. Jacobs is a professor of surgery and pediatrics in the Congenital Heart Center at the University of Florida Health Center at Shands Children's Hospital. He's also been a professor at Johns Hopkins University and has done many tremendous number of pediatric operations throughout his life. He's been the editor-in-chief of the Cardiology in the Young, as well as an associate editor for the World Journal of Pediatric and Congenital Heart Surgery, and a deputy editor of the Annals. Tonight, Dr. Jacobs is going to be presenting on the Society of Thoracic Surgery's National Database, and he served on this since its inception and served as the chair of it from 2015 through 2019. He's also got numerous accolades and awards throughout his illustrious career. He's written close to 700 peer-reviewed index papers. He's got 62 book chapters and 9 books himself. So it is indeed an honor to have Dr. Jacobs present this evening. on the use of the Society of Thoracic Surgery's national database, really looking at what is new. And this is an evolving database that has changed tremendously. So I look forward to hearing Dr. Jacobs' presentation. Dr. Jacobs? Jeff, I think you're muted.
Thank you very much, Al. I'm glad you told me that before I got to the 30th slide. First of all, you can see my slides now? And you can hear me. All right, well, thank you for your kind words and your generous introduction. That was very meaningful, and I appreciate everything that you said. It's an honor for me to speak at this webinar to this particular group. It was reminded me that I was on the very first webinar that this group started at COVID time. And when COVID started, these webinars started, and it's amazing to me the quality of the content and how these webinars have grown. I place very high value on my collaboration with Al and with Eric and other colleagues at SpecialtyCare. We've done some great research during COVID, and I'm very honored to have the opportunity to speak to y'all today. My assigned topic is the Society of Thoracic Surgeons National Database, What is New? I've thought a lot about what's the best way to approach this topic. And what I decided to do was pull 4 articles from the literature that have been recently published within the last year that talk about new directions that the STS database is moving, and focus on 4 specific research articles. Okay. Now, what we're going to talk about today with these specific research articles involves the intersecting domains of outcomes analysis, research, and quality improvement. And the STS database and many databases have the goal to serve as platforms for outcomes analysis, platforms for research, and platforms for quality improvement. And the definition of outcomes analysis, quality improvement, or research really varies from place to place. And depending on which IRB one is working with and which institution one is working within, the borders between quality and research can be blurred. And we're talking about today the Venn diagram and relations between outcomes, quality, and research. Now, before I give my database talk, I was thinking a lot about this talk, and I started to say to myself, well, why are databases important? What's important about a database? And I started thinking about ECMO, and I started thinking about COVID. And obviously, COVID has been in the news a lot in the last 2 years. ECMO has been in the news a lot in the last 2 years. And the use of ECMO to save lives of COVID patients has been in the news the last 2 years. But perhaps never in cardiac surgery has cardiac surgery databases been so important as in the time of COVID, as we all struggle to figure out, should we use ECMO for COVID patients? Which COVID patients should be treated with ECMO, and how should we treat them? And under the leadership of Al and Eric and my colleagues that I work with at SpecialtyCare, we began looking at our ECMO patients very early and creating a database very early in the time of COVID. And just during the lockdown and in the first months of March and April of 2019, we started looking at, actually March and April of 2020, and we started looking at our first initial experience with ECMO and COVID to find out, should we use ECMO? And we had 32 patients in the first month of the pandemic. We published them in the SIO journal, and we studied them to try to learn what we could do better. And then we kept this database, and it grew, and we went from 32 patients to 100 patients, again in the SIO journal, then 200 patients in the Annals of Thoracic Surgery, then 505 patients in the Annals of Thoracic Surgery, and most recently now 594 patients in the Journal of Thoracic and Cardiovascular Surgery. We're not going to talk about any of the data related to COVID today. I think we're all tired of talking about COVID. But the reason I bring this up is twofold. One, to acknowledge this tremendous collaboration I've had with Al and Eric and others at SpecialtyCare. These are good people and good scientists. And my collaboration with this team has been one of the highlights of my career. And second, to exemplify why understanding and using databases are important. It's not just typing numbers into a spreadsheet and then having a statistician run p-values on them. This information can really change care and save lives, and never before have I seen it so obvious as with all of our COVID research. And this COVID research has led to our group putting together these 9 studies, which I think, I truly believe, have saved lives across the country as people have learned about using COVID for ECMO. And that, in my mind, is why databases are important. What I'm going to do today related to the STS database is I'm going to look at these 4 papers, all published in the last year, that reflect on different aspects of the STS adult cardiac surgery database. The first one talking about penetration, completeness, and representativeness of the database itself. The second one talking about the coronary artery bypass grafting composite measure. The third one talking about multiple valve operations and how we measure quality in multiple valve operations. And the last one talking about the most recent STS quality measure, which is the participant level multi-procedural composite measure for adult cardiac surgery. Similar talks can be given about the STS database for general thoracic surgery and pediatric heart surgery, but today we're really focusing on adult heart surgery. And I want to go through these 4 recent publications, and about each publication answer one simple question: why is this paper important? So let's start with the first bullet point here in red, the paper about penetration, completeness, and representativeness. In 2010, we published a paper with the STS database where we successfully linked the data in the STS database to Medicare data. And by linking 2 databases together, we were able to answer questions that neither individual database could answer alone. The STS database has very detailed clinical information about perfusion, about surgical strategies, and about short-term outcomes. The STS database does not contain information about long-term outcomes and healthcare economics. Medicare data has lots of data about long-term outcomes and healthcare economics, but lacks information about the technical details of the operation and perfusion strategy. So by linking those 2 databases together, we were able to begin to use the STS database along with Medicare to answer specific questions about the longitudinal outcomes and healthcare economics of different forms of cardiac surgical treatments, and do comparative effectiveness research over the length of time with outcomes, not just short-term survival, but long-term survival, long-term morbidity, and cost. That was the value of the STS CMS link. The STS CMS link also allowed us to answer questions related to the penetration of the STS database. In other words, how many hospitals do heart surgery in the United States, and how many hospitals send data to the STS database? How many patients have heart surgery in the United States, and how many patients of those that have heart surgery in the United States get entered into the STS database? So in 2010, when we created this linkage, we began to study these questions about penetration. Then in 2016, we updated the linkage with linked data that was more recent. And most recently, after these 2010 and 2016 linkages, we updated the linkage again in 2021, which is the most recent paper about the penetration, completeness, and representativeness of the STS database that I want to spend a moment talking about today. Now, the rationale, the rationale for this linkage is like I described before. I'm just going to move something on my screen here real quick. I have a picture of Al above a bullet point. Okay, that's better. So like I described before, the rationale for this linkage was based on the principle that the evaluation of long-term patient outcomes is a key goal of the Society of Thoracic Surgeons. And despite the many strengths of the STS database, a drawback of the STS database has been the lack of any follow-up information beyond hospital discharge and 30 days after the procedure. Medicare data complements STS data by providing crucial information about long-term outcomes and cost. The purpose of the study that I'm going to describe now was to utilize linked data from the STS CMS linkage to examine the penetration, completeness, and representativeness of the STS adult cardiac surgery database. So we used variables common to both the STS and Medicare databases, and with those variables, we linked operations in the Society of Thoracic Surgeons database to Medicare data and Medicare records. And we did this for all coronary bypass graft operations discharged in the United States between 2000 and 2018 inclusive, so 19 years of data. And we said for each CMS hospitalization, we wanted to find out whether or not a matching STS record existed for CABGs. Now, to understand the study, we need to understand a few crucial definitions. First of all, the definition of penetration for this analysis. Center level penetration is defined as the number of Medicare sites with at least one participant in the STS at that site or hospital, divided by the total number of Medicare sites that do coronary artery bypass grafting. So it's a fraction, how many sites have STS participants over the total number of sites. That's the penetration. Patient level penetration is a little bit different. It's the number of CMS CABG hospitalizations done at STS sites divided by the total number of CMS CABG hospitalizations. In other words, how many of the CABGs done in the United States were entered into the STS database. Completeness of data looks at each individual site and says that if a hospital participates in the STS database, how many of the CABGs done at that hospital were actually entered into the database. So it's the number of CABG cases at a hospital that are entered into the STS database divided by the total number of CABG cases. So this is a busy table that begins to show the results for center level penetration from 2000 to 2018. And I'm going to zoom in on this to show some of these numbers more closely and focus on it. So this big arrow points to the center level penetration of the STS database in 2000. And what this number means is that of all the hospitals in the United States doing CABGs, 45% of them were participating in the STS database in the year 2000. Then this next arrow here shows that by 2018, 19 years later, instead of 45% of the hospitals participating, it went up to 95%. So that's a pretty impressive growth of hospital participation in the STS database. And this is a map that shows all the states in the United States and shows the percentage penetration in a given state. So down here in the great state of Florida, 100% of the hospitals that participate in the STS, that 100% of the hospitals that do coronary bypass surgery send their data to the STS database. And that's because the state of Florida passed a law that to do CABGs, you have to participate in the STS database. And we can see that there's many states with 100%, but there's some with less penetration. The overall penetration on the slide before here is 95%. Now, this is even a busier table, so I'll zoom in more closely, but this is a table that looks at patient level data rather than hospital level data. And we can see that in the year 2000, 51% of the coronary artery bypass graft operations done in the United States were entered into the STS database. Meanwhile, in the year 2018, 97% of the CABGs done in the United States were entered into the STS database, a big increase in patient level penetration. And next we look at completion. The STS database at any given hospital was complete 88% of the time in 2000. That's now gone up to 98%. This is a map of the United States showing patient level penetration stratified by state. And this is a graph that's the Facebook representation of this study. And it shows how from 2000 to 2018, we increased our penetration at the level of the patient and at the hospital, and we also increased our completion. And most importantly, from this study, we now know that 97% of the coronary artery bypass grafting operations done in the United States are entered into the STS database. So if we zoom in on this, we can really see the importance of this information, and that information has value. From this study, we can conclude that the successful linking of the STS adult cardiac surgery database and the Medicare database demonstrate high and increasing penetration and completion of the STS database, and that the STS database now has 97% of the cabbages in the United States. So coming back to the question, why is this important? Well, this is important because of the basic fundamental reasons that we have a database. We have databases to measure and assess quality, to benchmark, to improve quality, to do research, to provide transparent sharing of data to patients and families, and to give data to multiple governmental agencies. And if the data is complete and accurate, we can accomplish all of these goals better. I'd like to comment briefly on the role of the STS database for professional advocacy related to the National Quality Forum and the CPT codes and the Relative Value Unit Update Committee, all of which is very closely related to this high level of penetration. Let's say something about the National Quality Forum. The National Quality Forum is a multiple stakeholder, not-for-profit, nonpartisan, membership-based organization that works to catalyze improvement in healthcare. What they do is they endorse quality measures. They're funded by membership dues. They have members that represent everyone with an interest in healthcare quality, hospitals, healthcare systems, patients, and families. They have over 400 member organizations, and their main goal is shown in red here, to review and endorse measures of quality. And the STS has a variety of rules and criteria to endorse a quality measure. The major review criteria are shown in red. The measure has to be important, be scientifically acceptable, feasible, usable, and it has to have a favorable comparison related to competing measures. To get a measure endorsed by NQF typically takes a year and a half. And STS has 34 quality measures that are endorsed by the National Quality Forum based on the STS database. This is the most quality measures of any professional medical society. If one goes to the STS website at this hyperlink shown on this slide, we can go to this page that lists all the STS performance measures. And STS has performance measures for adult cardiac surgery, for coronary bypass grafting, composite score, renal failure, surgical re-exploration, wound infection, and stroke after CABG. There's measures for use of antibiotics. There's measures for participating in the database itself. There's a composite score that evaluates the composite performance of an individual surgeon. There's a variety of congenital heart surgery measures that I won't talk about today that evaluate the quality of congenital heart surgery, and similarly, a variety of general thoracic measures. The measures are divided and stratified by Donna Bedian's triad into structure measures, process measures, and outcome measures, and composite scores that mix multiple measures together. We can see that most of these measures are for adult cardiac, but there's also, again, general thoracic and congenital heart surgery measures. For adult cardiac surgery, there's structure and process measures that look at participating in the database using beta blockers, both before and after surgery, using antiplatelet medications, anti-lipid medications, utilization of the mammary artery, and perioperative antibiotics. Then there's outcome measures that look at complications like stroke, renal failure, prolonged ventilation, re-exploration, deep sternal wound infections, and readmission rate. Then there's outcome measures that look at mortality for coronary bypass grafting, for isolated AVR and MVR, for AVR and MVR combined with CABG, and for mitral valve repair combined with CABG. And then there's composite scores that look at the composite quality, looking at the combination of mortality and morbidity for CABG, AVR, MVR, AVR CABG, MVR CABG. In general thoracic surgery, there's participation measures, there's lung cancer measures, both for mortality and morbidity. And in pediatric heart surgery, there's a number of measures related to outcomes after pediatric heart surgery. These 34 measures make STS the steward for more NQF endorsed quality measures than any other specialty-based medical professional organization. Therefore, the fact that NQF is the gold standard for healthcare quality measures reflects very favorably on the quality of the data in the STS, because NQF measures are endorsed when they're recognized nationally as best-in-class, evidence-based, and valid. In addition, many of these measures that are quality measures are also used and tied to reimbursement from the federal government for CMS reimbursement plans. And that's fairly important for the financial viability of hospitals. And I think it's good that the quality measures used to assess reimbursement to hospitals and to physicians come from the STS database. So to summarize, why is this important? This is important because NQF measures are used by multiple stakeholders to assess the quality of care. Now, I'm not going to talk very much about CPT and the RUC. These are the organizations that code cardiac surgical procedures and assess the value of cardiac surgical procedures for the federal government. And these organizations use STS data in order to accomplish these goals. I do want to talk a little bit about Sts Composite Measures to make the information I'll share in my subsequent talks about the papers a little more understanding. So I'm going to say a little bit about the current composite measures that the STS uses from the STS database. And I'm going to focus specifically on CABG and valve composite measures. The CABG composite measure takes data from the STS database about risk-adjusted mortality, risk-adjusted morbidity, mammary artery utilization, and evidence-based perioperative process measures related to perioperative medications, combines it all together to a composite score, and then stratifies providers into 1, 2, or 3-star providers or hospitals based on a 99% Bayesian probability that a 1 or a 3-star differs from a 2-star. So this is a bell-shaped distribution of the CABG composite scores. And this shows the science behind this. And Eric can probably talk about this slide better than me, but it shows that an outlier has a 98% Bayesian probability that they're actually different from a 2-star non-outlying program. This shows that in the STS database for the CABG composite score, about 10 to 15% of hospitals are high-performing and low-performing outliers every year based on the metrics in the CABG composite. The AVR composite has only 2 domains, mortality and morbidity. It doesn't have any medication domains or process domains. So again, for the AVR one, risk-adjusted mortality and risk-adjusted morbidity are mixed together, and a star rating is calculated. The IMA, there's no IMA measure for AVRs because that only applies to CABGs. And unlike the initial CABG composite that was based on 1 year of data, AVR composite is based on 3 years of data because the operation is performed in rarer instances. This is the bell-shaped distribution and the percentage of outliers for isolated AVR. Here's the same information for AVR combined with CABG, 2-domain composite for mortality and morbidity, 97.5% Bayesian probability that an outlier is a true outlier. And here's the bell-shaped distribution. And again, most hospitals, 90% are 2-star hospitals, but 2 to 7% are outliers year after year. The STS also has recently released composite scores for lobectomy, mitral valve, and mitral valve combined with CABG, and also esophagectomy. Now I'd like to move on to paper number 2. This paper talks about the coronary artery bypass grafting composite score and an update to the methodology in 2021. So we just talked about the CABG composite, 4 domains, 1 year of data. Dave Shahian and colleagues recently published a paper looking at the CABG composite and updating the methodology. So the original CABG composite measure had 1 year analytic cohort and a 98% credible interval to identify outliers. So this means that a certain percentage of programs were identified as outliers based on 1 year of data and 90% intervals. But as CABG volumes per STS participant, hospitals or practice groups have decreased, it has become more challenging to classify performance categories using this approach of 1 year of data, especially for lower volume programs. So this study was designed to explore alternative approaches. And this study looked at 990 hospitals that do CABGs, and performance classifications were studied using various analytic cohorts. A 1 year cohort, a 3 year cohort, a cohort of the last 450 cases within 3 years, and even the most recent year plus additional 450 cases. And these different methods were compared to what was being used, which was 1 year of data. This is a table that shows all the different strategies that were available and were studied in this cohort. and the number of outliers identified as 1, 2, or 3-star programs. And with the current method of 1 year of data and 98% credible interval, about 4% of programs to 6% of programs were identified as high performing or low performing outliers. But if we change that to 3 years of data rather than 1 year of data and change the credible interval from 98 to 95%, then we have about 2/3 of programs being performing as expected, and the remaining 1/3 being divided up amongst high performing and low performing outliers. So in 2021, the Society of Thoracic Surgeons CABG composite was updated compared to the previous methodology, and now the CABG composite uses a 3-year analytic cohort and a 95% credible interval, which increases the number and proportion of better or worse than expected outliers, especially among low volume hospitals. And also, this revised CABG methodology is now consistent with the methodology used for valve procedures. So the bottom line here is that the original CABG composite used by the STS, which was a 1-year cohort and 98% credible intervals, is now changed to a 3-year cohort with 95% credible intervals. The next study to talk about is the STS 2021 Adult Cardiac Surgery Risk Model for Multiple Valves. And this paper was also recently published in the Annals of Thoracic Surgery. As I said before, STS for adult heart surgery had a CABG composite, AVR composite, MVR composite, and an AVR plus CABG and an MVR plus CABG composite score, plus a score for individual surgeons. We did not have a tool to evaluate multiple valves like an AVR plus MVR or an AVR plus MVR plus CABG. So this study was designed to create risk models for multiple valves. What we did was we took data from 2011 to 2019, and we developed risk models for AVR plus MVR based on 30,000 operations across the United States, and AVR plus MVR plus CABG based on 12,000 operations across the US. The endpoints of this model were 2 domains, operative mortality and major morbidity, which is defined as reoperation, sternal wound infection, stroke, or combined mortality and morbidity. This is a busy table that shows the number of operations done in each category over the last several years in the STS database going back to 2011. So for example, we know that the STS database had 71,993 CABGs in the 6 months from July 1st, 2011 till December 31st, 2011. This breaks this number of cases down for all the different case types. And what I want to do here is I want to focus specifically on some of the case types, the newer ones. So you can see, first of all, CABG in this time interval from 2011 to 2019, the STS database had 1,234,016 CABGs. That's a lot of CABGs, over 1 million. Meanwhile, in the same time interval, we only had 6,000 patients that had AVR plus MVR plus CABG. So big difference. Then if we zoom in on the actual number of operations done per year based on these different operation types. So what I've done is I'm going to go to the previous slide, and in the previous slide, we take what's in yellow and consolidate it. So now we're just looking at what's in yellow. We can see quite clearly how much of each operation type has been done over this time period in the STS database. And we can see the percentage that these operations make up of the STS database. So half of the STS database is CABGs, and less than 1% is AVR plus MVR plus CABG. The new multi-domain risk model that we're talking about here involves just the 4 operations that are shown on this slide, which is AVR plus MVR, AVR plus MVR plus CABG, involving either mitral valve repair or mitral valve replacement. Each of these operations involves less than 1% of the STS database, but including these operations within the STS database and evaluating their quality is very important for hospitals that do a higher percentage of these complex procedures. So they're rare operations, but in some hospitals, they're done more frequently and make up a higher proportion of what's done at that hospital. This slide shows for these rare operations how frequently they die or have postoperative morbidity. So if we look very, very closely, excuse me 1 second, I'm getting paged like 97 times, and I just want to make sure it's nothing bad. Okay, this is all manageable and can wait. I've never been paged so much in 2 seconds before. I'm sorry about that. Anyway, if we look closely at this slide, we can see the number of patients that experience mortality and morbidity in each of these groups. And unlike a CABG that has a mortality or morbidity of about 1%, these are higher risk procedures. So overall, the mortality after these procedures is 8.3%, and it's up to 13.5% for an AVR plus mitral valve replacement plus CABG. So these are high-risk procedures with more mortality and more morbidity. And here, this shows the mortality ranging from 4.8% for an AVR plus mitral valve repair to 13.5% for aortic valve replacement plus mitral valve replacement plus CABG. This shows the percent morbidity. About a third of these patients experience some form of bad morbidity. So STS has developed a new risk model to deal with patients who have had multiple valve operations, aortic valve replacement plus mitral valve repair or replacement plus or minus CABG. And these models are now being used by STS in a variety of performance metrics. And that's why this paper was important. This paper is important because these data are now used as a tool to evaluate quality of care for CABG combined with AVR, MVR, or just AVR plus MVR. And the last paper to talk about, and I only have a few slides about this paper, is the newest STS measure of quality, the multi-procedural composite. This also was recently published by Dave Shaheen and colleagues, and it was based on a multi-procedural composite for individual surgeons. Now, in addition to a multi-procedural composite for individual surgeons, we have one for programs. And this, again, it's based on operative mortality and major morbidity as defined on this slide. And it includes multiple different types of cardiac surgical operations: CABG, AVR, MVR, AVR plus CABG, MVR plus CABG, and all the multiple valve operations that we just discussed. By publishing this paper, we now have this tool to go ahead and take all of these operations together and have one overall composite score for a program looking at each one of these operations and their mortality and morbidity for these operations. And the new advance is it includes all the multiple valve operations that we just discussed. Using this new composite tool and 3 years of data, we can be very precise in identifying 1-star, 2-star, and 3-star programs because we have so much information. And here, about 60% of programs perform as expected, 26% perform better than expected, and 16% are performing worse than expected. So this tool then allows identification of suboptimal performance and initiation of quality improvement initiatives. This is the bell-shaped distribution for mortality and morbidity in the multi-domain composite. This is the bell-shaped distribution of the overall composite, looking at 1 year and 3 years of analysis. And again, as we showed before, this is the distribution of outliers with 1 year of data and 3 years of data. So why is this important? Because the multi-procedural composite measure provides comprehensive assessment of adult cardiac surgery practice in the United States, encompassing 81% of the total cardiac surgical cases performed by using all of these different operations. And this multi-procedural composite has exceptional reliability and effectively discriminates 3 categories of performance involving 81% of the operations done in the United States. So to summarize, I've tried to briefly talk about these 4 manuscripts, share information about why these papers are important for the STS database and for the practice of cardiac surgery. This information is important for all cardiac surgeons and all perfusionists. Again, I want to reiterate what I said at the start of this talk. We've learned from COVID that databases are important. We've learned that because ECMO was in the news. We've learned that from paper after paper after paper after paper after paper about ECMO and COVID, that databases can be used to save lives. And similarly, these manuscripts that I reviewed today, these 4 papers, are shaping the future direction of the STS database. It all boils down to outcomes, quality, and research, and using the database to improve the quality of healthcare we deliver. One way to look at this is that science tells us what we can do, guidelines tell us what we should do, but registries, databases tell us what we're actually doing. Or, as a famous data scientist said, and I put this slide in there for Eric Tisdale, without data, you're just another person with an opinion. Thank you for the opportunity to talk. It's been a pleasure, and I think we have about 20 minutes to answer any questions.
Jeff, that was superb. Thank you so much. What a great summarization of a tremendous amount of data. And I think if you had to estimate the number of really high quality publications that have come out of the STS database, I don't know if you have an idea, but it's got to be in the hundreds, if not, thousands.
Yeah.
It truly is the gold standard by which all databases are compared. Would you agree to that the STS database, set the bar very high for all other professional societies?
Yeah, there's absolutely no doubt that the STS. I'm going to stop sharing my screen if I can. There we go. There's no doubt that the STS database has not only set the gold standard for all other societies, but really is clearly viewed by the National Quality Forum, by the United States government as the gold standard for databases. And I think that there's many other subspecialties in medicine and in surgery that are now mimicking the STS database and trying to replicate that in their fields. Now, it's a fact that outcomes in heart surgery are pretty measurable. All the perfusionists on this call know that. If one's making a database for dermatology, the outcomes are a little bit more difficult to measure. But that being said, I think that there's no doubt in my mind that the STS database is the gold standard for databases for medicine and surgery.
Great. And I'm going to go ahead and start questions, and then we'll shift back and forth between the Q&A questions from the Zoom and Eric as well. But, we only have about 20 minutes left, so I'm going to ask for as brief an answer as possible, and I'll keep the questions as brief as possible.
You got it.
I'm going to throw a dart at you, Jeff. I mean, one of the big issues that the perfusion community has with the STS database is that there is so few variables that are actually recorded. Can you comment on that? I mean, are we just whining, or would you also assess that to be true?
Yeah, that's a great question, Al. I think STS has collaborated with different perfusion organizations, such as the Society for Evidence-Based Perfusion, to try to define the variables related to perfusion in the STS database. We've worked with Donnie Lakoski, Kenny Shan, many others. And I would agree that there would be value in adding more perfusion variables to the STS database. STS is faced with a continuous struggle between parsimony, making a small minimal data set in a small group of data fields that are manageable to enter, and capturing all the information in the world. And it's an ongoing battle that takes place at every database upgrade. That's why there's value in perfusion databases, such as the one maintained by SpecialtyCare, because those databases focus specifically on perfusion variables not captured in the STS. But my one-word answer, or my two-word answer to the question you just asked me, Al, is yes, I agree.
Okay, one of the questions in the chat session relates to cardioplegia. It says, hello, Dr. Jacobs. This is from Maureen Gray. In the future, do you see the database being used to influence cardioplegia techniques?
Yeah, I think in order to do that, the database has to capture detailed information about different types of cardioplegia. And I think, unfortunately, we capture some information, but perhaps not enough. The outcomes measured in the database are perfect to assess cardioplegia techniques. I think to truly do that, we either need to add more variables about cardioplegia in the STS database, or alternatively link the STS database to a perfusion database that has that information, which is very possible. Just like we linked it to Medicare data, we could link the STS database to a source of perfusion information at the level of the patient record, take the detailed information about perfusion from database A, the detailed outcome information from database B, and study cardioplegia. So bottom line is, yes, databases can be used to do that. And I think the STS is a prime source, but some of the information is lacking.
Thanks, Jeff. Another question from the chat room from an anonymous attendee is talking about the STS congenital database. We have a number of congenital perfusionists who are online with you tonight, Jeff. And the question is, I haven't reviewed this, but that the data is not available at the STS website. Is there going to be an update where the congenital data will be viewable by the general public and by the actual congenital heart centers?
Well, I think probably what that person is asking is that the publicly reported data on the STS website has not been updated since COVID. And I know that the STS Congenital Heart Surgery Database Task Force has plans to update this publicly reported data soon. About 90% of the hospitals in the United States that participate in the STS database have agreed to publicly report the data. In the past, this publicly reported data was updated every 6 months. It has not been updated since COVID, but I know STS has every intention of updating it soon. Obviously, the answer to this question depends on the definition of the word soon. All I can say is that the STS is doing everything possible to get the new refreshed data up there quickly.
Thanks.
That's a great question.
So, Dr. Jacobs, one question that occurred to me while you were describing, I think it was the second paper, talking about the change in the methodology for the star ratings and using 3 years of data instead of just one. I guess it's just a quick two-part question. First, what were some of the things that were being discussed to prompt such an investigation? I assume maybe there were some shortcomings with the old way of doing things. Secondly, I'm curious if you could just speak briefly on how will the STS know that it's happy with the new system? What will be the mark of success for the new system moving forward?
That's a good question. So the National Quality Forum and patient advocacy groups want these quality measures to be truly capable of identifying outliers. If a quality measure states that every single participant measuring their quality is performing as expected, it really doesn't have any value. And 10 years ago, when more CABGs were performed, there was enough data in the database to identify about 10 to 15% of programs as low performing and as high performing outliers. With CABG volume decreasing and CABG mortality decreasing, all of a sudden only 1 or 2% of programs were identified as outliers, a lot less. So one looked at, is it possible to develop a quality measure that will identify more outliers? And this especially was a problem with low volume programs, because low volume programs were in a situation that with 1 year of data, they would never be an outlier, or essentially never be an outlier, because they just didn't have enough cases. So by increasing to 3 years of data, more outliers were identified, and low volume programs had a chance to actually be identified as high performing programs, even though they were low volume, because more of their cases were taken under consideration. So the decision was made to create a more level playing field for low volume programs and to account for the overall lower volume of CABGs, and have a measure that could still identify outliers and give an opportunity for hospitals that are low volume to be a high performing outlier. I think how do we answer whether or not we're happy with the way it is moving forward? I think that's based on feedback from the membership of STS, as well as feedback from the National Quality Forum, as well as, most importantly, feedback from our patients.
Jeff, let me follow up with a question, kind of in the same realm of what Eric just asked. On one of your slides, you had Consumer Reports Health, the icon in that.
Yeah.
And as you're well aware, Consumer Reports on several occasions have reported STS outcomes in a generic way, but they reported it in a way that the general public could gain access to this without going to an STS database.
Right.
In a small number of the hospitals, in both of those reports, the hospitals had to agree to release that information. It was the star ranking. And I want to hear a comment from you, because in an editorial written in one of the issues, it said, and I'm closely quoting, if you're considering a hospital to have cardiac surgery and that hospital is not listed here, they chose not to share their data. So the STS has really did a lot of work on transparency. I think it's really one of the accolades for them that anybody can see at least those star ratings, the composite scores. What's your feeling on that comment being made in a publication such as Consumer Reports?
That's a really good question. I think a lot of people ask us at the STS, why doesn't everybody publicly report? And the STS is a professional medical society. It's not the government. The only people who can make somebody do things like pay taxes or publicly report their outcomes is the government. STS can just create the tools and allow people to voluntarily publicly report. So in the United States today, 95% of hospitals participate in the STS adult cardiac surgery database, 95% of hospitals that do heart surgery, and about 80% of those voluntarily publicly report. For pediatrics, it's about 95% of hospitals participating and about 92% of those publicly reporting, so even higher. When publicly reporting of cardiac surgical information started, only 30% of hospitals participated in publicly reporting, both in pediatric and in adult cardiac. And gradually over time, hospitals have become more and more comfortable with publicly sharing their outcome data. And the numbers have gone from 30% up to 80 or 90%. I think it's true that a hospital that doesn't share their information publicly, it's uncertain what's happening there. So I think it's very reasonable to want to examine this publicly reported data and use that as a guide to helping choose who your surgeon is going to be and who your hospital is going to be. There's a lot more that goes into it. I think the most important part of choosing your surgeon or choosing a hospital is the discussion directly between the patient and the surgeon. There's nothing more important than that. When a patient and their family is sitting in the room with the heart surgeon and the heart surgeon's nurse and talking about the operation and what they're going to do and what the expected outcomes are and how many times that surgeon's done that operation and what are the expected outcomes at that hospital by that surgeon, I think that's the most important part of choosing a surgeon. But I think this publicly reported information can help in those decisions. And I think the absence of publicly reported information can also help.
Thanks, Jim.
One more question from the chat. This is from Dominic Corella. He asks, are there external audits of the STS database?
Great question. Yes, the STS database spends tens of thousands of dollars every year on an external audit process, probably more than any other professional society on the planet. And in all three databases, adult cardiac, general thoracic, and congenital, 10% of hospitals are audited every year, and they're randomly selected. So although it's not 100% of audits, there's a random audit of 10% of hospitals in each database. That hospital involves detailed chart review and determining whether or not the information that's in the electronic health record matches the information that's in the database. So one word answer to that question, yes.
Right. There's a couple of really, all these questions that are being posed are phenomenal. I'm going to ask one from Stephen Dove, who really, I think,
I know Steve Dove.
Yeah, he hit the nail with the hammer here. You know, we've all complained about the definitions for renal insufficiency and failure that are used by the STS. And I don't know if we're doing that justify or not, but it just seems like, you know, if using any of the other criteria, rifle, KDIGO, that you get a higher reporting of renal insufficiency, AKI, that you would get if you're using the STS. And Steve's point's really well, because he said, is there a possibility with all of the research that's going on now with oxygen delivery, specifically using area under the curve, which seems to be the format most people are going to, that could be added to the STS? And, you know, there's a link, at least from what we know from reported literature. So I'm sorry, Jeff, if I'm not asking the question effectively, but Steve wants to know, can we see oxygen delivery being added, and will there be an update with the definitions for renal insufficiency?
Yeah, so what I would say is that, first of all, I would say hi to my friend Steve Dove. Steve is somebody I've known for a very long time. I know a Steve Dove that was a PA, became a perfusionist, and I've known him since I was like in residency. So if this is the same Steve Dove, who's a perfusionist and a PA who I've known since I'm a resident, I say hello to an old friend. If it's a different Steve Dove, well, you have a nice name. As far as this question, I think this is a very good suggestion. I think every 3 years, the STS evaluates what data we capture and tries to make the database better. I think adding more detailed information about oxygen delivery and about the parameters of renal failure is a very reasonable discussion to have. I think the best way to implement a change like that is to put together a one-page white paper describing what change is being requested and why. So if one wants to add in variables for oxygen delivery, say we would like to add the following variables. This is how we would define them and capture them, and this is why we want them. That could be summarized in one sheet of paper, and that could be shared with STS leadership. Furthermore, if somebody wanted to put that one page together and send it to me, I'm then happy to create an email string with the remainders of STS leadership and that person to engage in the dialogue. That doesn't mean for sure that all requests of entering new fields will be captured, but that provides a platform for any interested party to make a recommendation for the updates and upgrades of the database that take place every 3 years. And the idea that Steve is proposing seems like a good idea to me.
Thanks, Jeff. Thanks, Steve.
Steve has also confirmed his identity as you've described it. So
outstanding. Well, I mean, this goes way, way back. And I think Steve's somebody I know from the great University of Miami, a Miami Hurricane football fan. He knew me when I was like a resident learning how to take down mammary arteries. So that's great. It's good. And I'm glad you confirmed your identity, and it's great to hear your voice virtually through Eric.
They had a football team at one time, I believe. I don't know if they still do, Miami.
They're coming back, brother. Coming back, still ranked this year, still ranked this week, coming back.
So a little bit ago, you were talking about some aspects of the growth of the STS database and some of the challenges involved in sharing information. I'm curious if you could say a few words about how you see other specialties moving in this direction, or examples where you've seen it. It's such a powerful tool. I happen to have the experience working in the surgical literature, the spinal surgery literature, and there's an absence of an STS database. So any experience or perspective you could provide on how other fields could do the political work? It seems very difficult to get organizations to be comfortable with this.
That's a fact. It's hard work and it takes a lot of time and effort. I'll give you a few examples. In cardiology, there's the NCDR database of the American College of Cardiology that has adult and pediatric cardiac components, tracks outcomes after transcatheter interventions ranging from coronary artery bypass, from transcatheter coronary stenting to transcatheter aortic valves and transcatheter mitral valve procedures. So the cardiologists have been very aggressive and have created excellent databases. The American College of Surgeons has a database that tracks outcomes after a variety of different surgical procedures. I think that all of these are striving to become as good as the STS database, but they are all quite good. I work very closely with the American Academy of Dermatology. They have a database called DataDerm, and I'm their advisor to their DataDerm database. And I don't know a lot about dermatology, but I do know that a lot about making medical and surgical databases, and I've been working for several years with the dermatologists, and they've worked quite hard to put together a database called DataDerm. They've published 2 annual reports and the report of their database audit, and they're moving along quite well with a high quality database that's looking at different treatments for a variety of dermatological conditions, both benign and malignant. So I would say there's efforts ongoing in multiple subspecialties. The best way to do it is under the auspices of a professional medical or surgical society, like the Society of Thoracic Surgeons, the American College of Cardiology, or the American Academy of Dermatology. And I think that the benefits of doing this ultimately boil down to providing the ability to healthcare providers and physicians to deliver better patient care.
Great. And that's wonderful. I'm going to follow up with the last question by Val Hoppershad. Where it really makes a good point. And, he talked about that there are perfusionists, perhaps hospitals that are hesitant to get involved with databases. There's different types of databases. Our database, SpecialtyCare, is mandatory. You can't opt out of joining it. And databases such as Perform are voluntary. The STS is voluntary. So, we have a benefit as an organization that we have automatic entry of data into our registry, and it's something that has to occur. But his point was, what tools can one use to encourage more to get on board using database systems for the many reasons that you've presented today, Jeff?
Yeah, that's a fantastic question. And there's a carrot and there's a stick, right? You can influence somebody by making them want to eat the carrot, or you can influence by hitting them over the head with the stick. The government can force people to do this. That's a stick. Employers can force their employees to do this. If one works for a company that has a database and they're told they have to participate in the database, well, then they have to participate in the database. They don't get a paycheck. So that's ways to force people to do it, and that's convinced a lot of people to do it. On the positive side, one can incentivize people to do it. Different ways to do that include the U.S. News and World Report system that evaluates the quality of care for hospitals and ranks hospitals, gives out points for participating in different databases. And that incentivizes hospitals to provide the resources to participate in databases. Face it, it's expensive to do this. You have to pay an individual or more than one individual to enter the data. You got to apply the software to capture the data. So it's expensive to participate in databases. But US News has incentivized people to do this by awarding points in their hospital ranking systems for database participation. So anytime a hospital can receive an award or receive recognition for database participation, that will positively incentivize them to behave in that way. And I think that those type of initiatives really increase database participation.
And I think the AMSAC Pillar Award, which just started, Scott Snyder's done a wonderful job of running that. I think that also has a registry requirement to get an award of excellence as a perfusion program.
Yeah.
Jeff, this was wonderful.
Similar ELSO is another example, right?
Oh, good point. Good point. Jeff, this was Dr. Jacobs, this was absolutely wonderful. Dr. Tisdale, great presentation, nice summarization. And I want to thank you both for the great work you've done in preparing this and presenting it. Really was informative tonight. I want to thank all the participants who joined us this evening. And of course, those who were able to ask questions. I apologize if we didn't get to all of them, but I really encourage you to join us in future webinars, and if there are any ideas on subject matter that you would like to see addressed here, it would be our pleasure to invite individuals who you want to have speaking, or subject matter, we'll find the individuals. Please reach out. Dr. Jacobs' email is at the top here.
Yeah.
Dr. Tisdale's is at the bottom.
Yeah, feel free to email me about anything. I'm happy to engage in dialogues. And if you have suggestions for the STS database, I can share them with the proper people within the society. I again want to congratulate Maggie from SpecialtyCare, as well as Al and Eric Tisdale. This is good work that you guys are doing with these webinars, and it's been an honor to participate.
Wonderful, and thank you. Thank you so much, everybody. Maggie, like as always, you do such a wonderful job behind the scene. So thank you all. Wish everybody a great evening, and we'll see you next month.
Thank you, guys.